Dear Mr. Chairman, dear colleagues. The topic is the Epicardial VT Ablation in Focus, Insights and Take-Home Messages from 2025 document. Regarding this document, I have no conflict of interest. So during VT ablation, in 20 to 30% of the patients, we need to have an epicardial ablation. The history is very interesting. In 1990s, Davila found an article about laser epicardial photocoagulation written at that time by Stevenson, suggesting that we can ablate the VT from epicardium. And then he showed this article to Sosa, and also Sosa saw that during ablation of patients with Chagas disease, he can see some fragmented late potentials in coronary sinus. And finally, they did the first ablation in 1996. This is the document that we wrote and also endorsed by Asian Pacific Heart Rhythm Society, and my talk is based on this document. So this document have different sections. I just talk about some selected section of the document. The first one is criteria to consider epicardial ablation. And we know that the QRS morphology in lead 1 and also in inferior lead can help us to decide which VT originates from the epicardial side. But this is very important that not only QRS morphology, but as you see here, pseudo delta or maximum deflection index, it means the morphology criteria and some interval criteria we can use to suggest that the VT originates from epicardium. But all these ECG criteria is only applicable to patients with non-ischemic VT, and we cannot apply them to the ischemic VT patients. This is important. And the second point is the value of imaging, and that was the reason that we recommended that all the patients with non-ischemic cardiomyopathy who underwent VT ablation should have a cardiac MRI or CT before catheter ablation. And the value of imaging in patients with ischemic VT is less clear. So this is very important, as you can see here, when we use these triangle, the so-called Larry's triangle, to access the epicardium very close to our puncture site. We have the left internal mammary artery and left superior epigastric and also left musculophrenic artery. And if, especially in the anterior approach, we are very close to these arteries, and arterial injury can lead to massive bleeding, and we have always be aware of this anatomical correlation. If we remain and confine our puncture to this Larry space or this triangle, usually we don't have intra-abdominal organ injuries, even if we go for the posterior puncture. But as you can see here, if we go outside the Larry's space, we may injure liver and some other intra-abdominal organs. And with the anterior approach, the arterial injury may happen. That's the reason that, especially for anterior puncture, we had to push the puncture site below, so our needle has more distance with these major arteries. One important point, we summarized the steps of anterior and posterior approaches in our document, but one very important point is needle orientation. When we go for a posterior approach, we usually aim for the left side. But when we go for the anterior, if we go like the posterior approach, then there is a possibility for arterial injury. If we go for the anterior approach, then we have to target the clavicle and go more inside, so we have a safe distance from the major arteries. So in section 5 and 6, we discussed epicardial mapping and ablation. So we have different kind of substrate mapping, starting from electrogram analysis, voltage mapping, pacing techniques, pre-procedural imaging and image integration, and finally, functional mapping. However, we have the target of the ablation is not to create beautiful images, but to perform a safe and effective procedure that eliminate the arrhythmia as fast as possible. And before catheter ablation, we have to choose the appropriate strategy for each patient individually in an interdisciplinary manner. And we thought that it might be appropriate to use multi-electrode mapping for mapping on the epicardial site, which may be useful to accelerate and enhance mapping. And we also think that the non-inducibility and ablation of all late potentials is the preferred endpoint of the catheter ablation. However, each patient need a special individualized endpoint. Use of irrigated tip catheter is advised, and most of the writing committee members used 40 to 50 watts as the upper limit of the ablation power using RF energy in the epicardial space. So prevention and management of complication is an important issue in epicardial ablation. History of previous cardiac surgery, obesity, coagulopathy, and renal failure are important risk factors for complication. Although controversial, we can also use high pain ESD score to differentiate between high risk and low risk patients. There are many recommendations in this document regarding prevention of complications. Two are very important: is availability of immediate in-hospital cardiac surgical backup is advised in all the centers performing epicardial ablation to prevent rare but lethal, to manage rare but lethal complications during epicardial ablation. And the second one is visualization of the coronary arteries is very important. Pericarditis pericarditis after epicardial ablation is a very common problem, and that was the reason that we advised to use glucocorticoids like triamcinolone, and also some studies suggest that the colchicine may also help these patients, and at my center we routinely use triamcinolone and intrapericardial and colchicine for 2 weeks after epicardial catheter ablation. Pericardial effusion is a rare but serious complication. Tamponade is a rare but serious complication after epicardial ablation, and we also suggested that, for example, micropuncture or CO2 insufflation techniques may help to reduce the incidence of tamponade and inadvertent right ventricular puncture, so to reduce the risk of tamponade. The next possible complication is phrenic nerve injury, and this is very important. We have to localize, and if our ablation location is very close to the phrenic nerve, we have to use techniques to displace the phrenic nerve so we can prevent phrenic nerve paresis. This is one of our patients. So as you can see here, the ablation site was very close to the phrenic nerve. So we used the second guide wire and then used the balloon to displace the phrenic nerve and prevent phrenic nerve injury during ablation. So many patients had previous cardiac surgery. So in patients with bypass surgery, we have to consider surgical window and don't use the interventional access with subxiphoid puncture, and in other kind of patients, surgical access and surgical window may be appropriate, but also subxiphoid puncture still is possible. You see here one of the patients on the left side. You see the adhesions in the pericardium, and in some cases we can use an steerable sheet. We can use an steerable sheet and also the catheter to remove the adhesions and perform mapping and catheter ablation in the epicardial space. Here is one example of a patient with inferior wall myocardial infarction with previous unsuccessful endocardial ablation. And in this patient, the VT was epicardial, so despite bypass surgery, it was possible to go to the epicardial space, as you can see here, and do the mapping and ablation. This is one of the bypasses, so the anatomy is very important. We knew that the VT is coming from inferior and there is no bypass. So we cannot injure the bypasses on the coronary arteries. But when we do the epicardial ablation in patients with ischemic heart disease, especially those who are not completely revascularized, we have to be very careful because there are bridging veins that traverse via the visceral pericardium from parietal pericardium to the myocardium, and we can cut these veins, and these are a kind of natural bypass, and this can lead to massive pericardial effusion and tamponade and bleeding. And finally, we recently submitted a visual summary of the guideline, will be soon published in European Heart Journal. But just I want to focus on emerging tools that imaging integration is very important. Also new mapping catheters and tools and new energy sources like, for example, pulse field ablation may revolutionize the epicardial ablation in the future. At the end, I thank you for your attention.